Thank you. It's a pleasure to be here. I am particularly pleased to honor Wayne Kendrick, who I consider a pioneer in bringing dialysis and transplant to Eastern North Carolina. So this is a true pleasure for me. This is an important topic, I think, for you folks because there's an increasing number of patients with CKD in this country and a diminishing number of nephrologists to take care of them. So a lot of the work is going to fall to internists and primary care physicians in their care. Where's the forward button? On the computer? So let me talk first about measurement of renal function. The gold standard for measuring renal function is obviously an iothalamate 125 clearance, but this is costly, requires a 24-hour urine, exposes the patient to radiation, is not very practical. Most physicians today use a BUN and a creatinine. However, there are problems with the BUN and creatinine. This is a comparison of the serum creatinine and iothalamate clearance. Were I to show you the BUN, it would be the same kind of curve except broader. And what's important to realize here is that any particular creatinine, you can see that the GFR can vary from 20 to 100 cc's per minute. On the other hand, at a very low iothalamate of 20, the serum creatinine can vary from 2 to 8. So serum creatinine BUN are really crude markers of renal function. Gives you some idea of where you are, but you need to go further than just looking at a BUN and creatinine. So the creatinine clearance is the next step. This again requires a 24-hour urine, and as those of you that have tried to collect urines from patients, that's very difficult to get a patient to do and not very practical. So most of us, most nephrologists have moved to an epidemiologic estimation of GFR. And these are formulas that are derived from large epidemiologic studies of patients that have developing chronic kidney disease, and they've been correlated to iothalamate GFRs. And they're all based on the Cockcroft-Gault estimation, which is based on age, the serum creatinine, weight, and gender. The MDRD estimation is somewhat more sophisticated, but still rests on those same principles with race added. And the more recent CKD epi estimation is a much more complex formula, but is much more accurate. Now, no one of you is going to sit down and calculate these formulas. Most laboratories today will provide you with an estimation of GFR. Most of them use the MDRD, and there's a movement in the country to use the CKD epi formula, which is somewhat more accurate. They're not vastly different, and you can get them from almost any laboratory in this country. And that's what most of us use and what you will probably use in the future to estimate patients' renal function. So there's great consternation and concern about age and renal failure and what aging means. This is a study from NHANES 1988 to 1994 presented by the USRDS, in which they looked at patients over the age of 65 and found that about a third of them have a GFR that's near normal. However, about half of them have a GFR from 30 to 60, and about 5.9 million, or 21% of the patients, have advanced renal insufficiency. So as one gets older, one gets renal disease. This is better shown again in this NHANES study. This is increasing age. These are hypertensive patients, diabetic patients. And this is a population of non-institutionalized normal people. And you can see simply with age alone, there's a demise in renal function. So are age-related declines in GFR different than when you have a disease? Does it make a difference that it's just an old person getting decreased renal function? Well, all of the current estimations of CKD prevalence do not account for this age-related decline. And it occurs in about 70% of elderly patients. The rate of age-related progression is about 1 ml per minute per 1.73 meters squared per year, which means the average 55-year-old that gets to be 75 is going to lose 20 cc's of renal function simply because he got old. Well, does it make a difference? Probably not, in my view. The mortality rate is high in this population of patients no matter what. This is a study from O'Hare that shows in a large population of patients that as you drop the GFR, the risk of death increases. And as you get older, not unexpectedly, the risk of death increases. And in the population of patients that are elderly with compromised renal function, the mortality rate is exceedingly high. And that is almost all cardiovascular disease. That is the dilemma of the elderly patient that develops renal failure. So mortality is high. You're going to treat the risk factors and the comorbidity the same. Doesn't matter whether it's age-related or disease-related, you're going to treat them the same. In the end, the decision to initiate renal replacement therapy, which this is all about in the elderly, should be based on the patient's comorbidities and their expected quality of life, not their age. So age by itself does not preclude one from getting dialysis. The comorbidities do and should. So most of us in the nephrology field have moved to staging. I think probably in general medicine, most of you know about staging, or I hope you do. And certainly the government does. As you bill patients now with CKD, the government, Medicare, pays attention to the stage they're in, and that's how you get reimbursed. There are 5 stages, 1 through 5. Stage 1 is normal renal function, a GFR greater than 90. It occurs in about 10 million people estimated in this country. Stage 2 is 60 to 90, about 22 million people in this country. That's the biggest population of patients in this staging. Stage 3, 30 to 60 ml per minute, about 6 million people. And these are people that are now becoming symptomatic. These are the people that are now becoming a problem to manage. Stage 4 is severe, 15 to 30 cc's per minute. It says 363 here, that slide's dated. That number is more like 450,000 in this country today. And the final stage 5 is kidney failure. That's people with a clearance less than 15 or on dialysis or with a transplant. And that number is now closer to 425,000 patients in the United States. So that is the way that we talk about, and throughout the rest of this talk and probably for the rest of your career, we will talk about kidney disease and its progression. Now, as you might expect with decreasing renal function, there's increasing laboratory abnormalities and increasing symptoms. The staging matches what's going on with the patient. And this is better illustrated in this cartoon, in which this is BUN and creatinine. It could be decreasing GFR as well, and this is time. So many patients that get a renal disease will have abnormal urine, they'll have a sediment, they'll have protein, or they may not have protein, they'll have isostenuria, and little else. When they develop hypertension, that is a signal that things are serious in this patient's kidney disease and they're likely to have problems. And after that develops anemia, and then a host of problems related to calcium, phosphorus, and PTH, metabolic changes that occur, and the patient's relatively asymptomatic during this period of time. They then develop a group of symptoms related mostly to salt and water and uremic toxins, and the final step is these end-stage uremic findings like uremic frost and asterixis and coma that we no longer see in this country. I suspect most of you that trained never see these. When I was an intern, we saw a lot of that because dialysis was not available. The important thing to understand here is that the signs and symptoms escalate as renal failure progresses. You may spend long years down here with not much happening. Once the patient develops hypertension and anemia, things are going to escalate. Things are going to happen quickly. Whereas we're talking about years down here, we're now talking about months. So when patients start down this track, you have to think ahead as what am I going to do to have this patient prepared and keep them out of trouble. So that requires an approach to renal failure, and many of us use this kind of buckets of therapy to think about where we're going. The first bucket is interventions that delay progression. How am I going to keep this patient from developing renal insufficiency? And that should be applied in the early stages when the patient has early renal disease. There's a bucket of therapy that is related to reducing uremic complications, and that occurs generally in stages 2 and 4. Then we want to modify comorbidity. I'm talking primarily about cardiac and vascular diseases at this point, and that's in stage 3 and 4. And finally, stages 4 and 5 is where we prepare the patient for dialysis and transplantation. So that's a nice way that most nephrologists think about how am I going to approach the patient, and you should incorporate in your thinking as well. So let's go back to the first bundle of therapy, those things that we can do to delay progression. It's important for you to understand the role of diabetes and hypertension in this scenario. Here is USRDS data, United States Renal Data System, and I'm going to quote them a lot. That's where a lot of our data comes from now. This is the way Medicare collects all of the claims data and gives it back to us. You can see that diabetes and hypertension have a count and a rate much higher than any other cause, glomerulonephritis or cystic disease. In fact, diabetes and hypertension account for about 85% of the patients on dialysis. So you're going to have to pay attention to diabetes and hypertension if you're going to take care of people with kidney disease. Here's work done a number of years ago in the Mr. Fit study of about 330,000 men, in which one compared the stage of hypertension with the appearance of ESRD. And you can see clearly that the worse the hypertension, the higher the stage, the more likely one is to get ESRD. So hypertension is a big player in causing ESRD. And obviously, your approach to hypertension is going to be important in delaying that progression. This is a meta-analysis done of a large number of studies a few years back in which it's shown that there's a pretty good direct correlation between the systolic pressure and the loss of GFR. The higher the blood pressure, the greater the GFR loss. Now, you could argue, well, it's the other way around, Michael. It's as you lose GFR, your blood pressure goes up. How do you know which one is which? And we don't know. It really doesn't matter, because you're going to have to treat hypertension anyway. That's the only way we're going to, nothing else am I going to do over here to affect the GFR, but I may affect hypertension and change that correlation a bit. So here are the blood pressure management and hypertensive agents and the way we'd use them. These are the types of kidney disease: diabetic kidney disease, non-diabetic with proteinuria, diabetic kidney disease without proteinuria, and I'm not going to talk about kidney transplants today. So in all of these categories, the goal is 130/80 or less. That is what we'd like to get all of our patients. Now, when this chart was made, the goal in general medicine, I think, at that point in my career, was probably 140/90. As I go to see my internist now, he tells me it has to be lower, at least mine does. He wants me to be at less than 130/80. And so I think the general population of patients is moving down. Does that mean that the patients with CKD should move further? Well, I can't answer that, but clearly, all of your CKD patients, you should strive to get less than 130/80. Being careful not to volume deplete those elderly patients and where volume can precipitate renal compromise. So the agents of choice in diabetic kidney disease and those with proteinuria is clearly an ACE inhibitor and ARB. I think there's sufficient data to suggest that that's the treatment of choice now. If you need other agents to reduce cardiovascular risk or control hypertension, it would be diuretics, then beta blockers, then calcium channel blockers. In the patients without proteinuria, there is no preference, and one generally goes diuretics, ACE or ARB, beta blocker, calcium channel blocker, but that's not hard. It could be anything. But most of these patients do in fact require combination therapy in my experience. This again is a large group of studies that were looking at non-diabetic renal disease, and this was not the treatment of hypertension. This was simply giving ACE inhibitors to a group of people to see if you could slow progression in non-diabetics. And you can see the outcome. It's about half of them ACE were effective, and in half they were not effective. So there's some question in a non-hypertensive, non-diabetic patient, are ACEs and ARBs effective prophylactically? If you look closer at these studies where ACEs were effective, they had a higher penetration of people that spill proteinuria. So again, in the patient with heavier proteinuria, you're more likely to have a beneficial effect using an ACE and ARB inhibitor. And those are populations of patients you should single out. So in the diabetic patient, it's clearly different. In the diabetic patient, this is type 2 diabetes, survival. This is no albumin spillage, and age-matched controls, there's no difference in mortality if you don't spill albumin. But once the diabetic starts spilling a small amount of protein or even a large amount of protein, mortality increases. So albumin spillage is not only a predictor of progression, it's a predictor of outcome, and it is a sign that you need to pay attention to. Not quite so important in the non-diabetic, but clearly an issue in the diabetic patient. So you know, what are the strategies now in a diabetic patient with CKD? Treat the diabetic patient with ACE and ARB inhibitors. Treat the diabetic patient with CKD. Treat the diabetic patient with ACE and ARB inhibitors. Treat the diabetic patient with CKD. Treat the diabetic patient with ACE and ARB inhibitors. Treat the diabetic patient with CKD. Treat the diabetic patient with ACE and ARB inhibitors. Treat the diabetic patient with CKD. Treat the diabetic patient with ACE and ARB inhibitors. Treat the diabetic patient with CKD. Treat the diabetic patient with ACE and ARB inhibitors. Treat the diabetic patient with CKD. Treat the diabetic patient with ACE and ARB inhibitors. Treat the diabetic patient with CKD. Treat the diabetic patient with ACE and ARB inhibitors. Treat the diabetic patient with CKD. Treat the diabetic patient with ACE and ARB inhibitors. Treat the diabetic patient with CKD. Treat the diabetic pat blood pressure control. Hypertension, I don't care what the protein spillage is, if they got hypertension, control their hypertension. That's number one in all of these patients. Now, a lot of people talk about tight glucose control, that is blood sugars multiple times a day, small frequent doses of insulin, and the value of that. I think most of us believe early in diabetes, before the patient spills protein, while they have normal renal function, that may be important. Once they start spilling protein, and clearly when they have heavy proteinuria, tight glucose control doesn't do anything. Now, I'm not suggesting you don't use tight glucose control in your diabetics, but you should use it for other reasons: retinopathy, neuropathy, cardiovascular disease. Once you start spilling protein, this treatment is not going to have much of an effect on the progression of renal disease. ACE inhibitors do have a very important role in the diabetic. They may not have much value early, before the patient has protein spillage and before they have compromised function, but as they progress, the use of ACE inhibitors, with or without hypertension, is extremely important and should be used in most diabetics from my viewpoint. This is one of many studies. This is Lewis's study in the New England Journal of Medicine. This is now 20 years ago, in which we looked at control patients. These are patients that did not receive an ACE inhibitor with diabetes, and these are patients that did receive an ACE inhibitor. And you can see the differences in survival at 4 years with and without those two agents. Most of the studies have supported this. ACE inhibitors are extremely important in the diabetic patient with CKD. Now, despite that knowledge, despite all we've found in all the studies about the use of ACE and ARBs and other antihypertensives in controlling hypertension, they're infrequently employed. Now, this is a dated study. This is Bill McClellan's work from 1997, in which he looked at excuse me, diabetic patients and hypertensive patients with proteinuria and diabetic patients and hypertensive patients with renal compromise, and looked at the percent of patients discharged from the hospital on an ACE inhibitor. You see that a third of the patients, whether proteinuria or decreased renal function with diabetes, only a third received an ACE inhibitor. And in the hypertensive patients, a little more than 10% of the patients with proteinuria received an ACE inhibitor, and about a quarter of the patients with compromised renal function. Have we gotten better? I mean, that clearly to me is not very good. Well, this is more recent data. This comes from the United States Renal Data System, and this was published in 2008. And it was looking at Medicare Part D claims and market scan claims. Those are commercial group practice patients. Looking at a claim for one of these drugs 12 months after the diagnosis was made, and these are the CKD codes that were used, and you can see those along the way. So in 2008, ACE, ARBs, and renal inhibitors were used in about 60–80% of patients with diabetes and hypertension. Maybe that's okay, but that means that 20–40% were not treated. So I guess it depends on your viewpoint whether that's adequate or not. If we look at beta blockers, again, the same outline, the same population of patients, about 60% of hypertensive patients received a beta blocker, a much greater number with congestive heart failure, which tells something about the way physicians practice in this country. And looking at calcium channel blockers, again, for hypertensive patients, a much lower number, about 30–40% of patients are receiving a calcium channel blocker. And finally, diuretics, about somewhere between 40–50% of patients are receiving a loop diuretic, particularly those in stage 4 and stage 5. Somewhat lesser percent of patients receiving a thiazide, and appropriately, very few patients in this category receiving a potassium-sparing diuretic. Clearly, that's not what you want to use in this population of patients. So I've shown you each of the categories. You might say, well, if I added them all together, there might be a higher percentage. There may be. They didn't give us that data. But at the end of the day, it suggests to me that drug therapy may be underutilized in the CKD population, whether with or without hypertension or with or without proteinuria. I hope that more and more patients will be receiving antihypertensive and ACE inhibitor therapy when they advance through their renal failure. So now going to the second bucket of therapy, and these are to prevent the complications of malnutrition, anemia, and osteodystrophy in this population. This is a chart from 1999 that shows the distribution of serum albumins at the start of dialysis in this country. The mean serum albumin was 3.2, and about 2/3 of the patient had an albumin less than 3.5. Now, maybe you don't accept hypoalbuminemia as a sign of malnutrition. In most of the studies I've seen, patients starting dialysis have clinical findings and anthropometric measurements that suggest, in fact, malnutrition is a common problem in this population of patients. Now, the dilemma is here. Many of the things we do to slow progression is restrict protein. In obese diabetics, you want to restrict calories. You want to restrict phosphorus to prevent osteodystrophy and metabolic bone disease, and you want to restrict sodium in the treatment of hypertension. What the patient hears is don't eat. And that magnifies the problem of malnutrition. So when we treat malnutrition, we do exactly the opposite. I want to give protein, I want to give calories, I want to give vitamins and supplements, and I want to give sodium bicarbonate for acidosis. So there's the dilemma. And you have to address each individual patient separately. You must decide, is my patient malnourished? And if he or she is, then I'm going to have to take a different approach. I'm not going to restrict things. I'm going to have to feed this patient. In my view, malnutrition at the start of dialysis is far more deadly than an earlier start to dialysis. So I don't delay progression of the start of dialysis and transplantation while sacrificing nutrition to do that. And I think that's an important concept. A dietitian is crucial in this. These are complex, difficult to care for patients, and I think a dietitian will play a very important and helpful role to you. You should consider comorbid conditions such as bad teeth, inability to eat, pyorrhea. Those are all problems in these patients. Gastropathy in the diabetic patient. And finally, depression. All of these patients with chronic kidney disease facing dialysis and transplant are depressed. And that has an enormous effect on their appetite and their consumption of food. Finally, in the patient with profound malnutrition, I think many of us now say, I'm not going to restrict, I'm going to feed the patient. If they happen to develop symptoms from increased protein, so be it. I'm going to dialyze them or transplant them. Malnutrition is the culprit here, and I do not want my patient to be malnourished. Turning now to anemia, again, a distribution curve of the levels of anemia at the start of dialysis in the United States. And this is 2000. And I'll tell you how this distribution curve has changed over the years. Back at that time, the mean hematocrit at the start of dialysis was 28%, pretty low. And at least half the patients had a hematocrit less than 30. That's rather severe anemia at the start of dialysis and has an impact on patients, I believe, that is quite severe. Now, this is a risk of death curve that was done in dialysis patients in the company that I work for, and we did this several years ago and showed if the reference group of patients had a hemoglobin of 11 to 12, as the hemoglobin dropped 10 to 11, 9 to 10, less than 9, the risk of death goes up rather significantly. In fact, back in those years, we found that as the hemoglobin went up, the risk went down. Well, I'll point out that this is a retrospective observational study of patients on dialysis. In more recent work, and most of you probably heard about these, this is the Choir study, which was done in CKD patients, not dialysis patients, in which it was a randomized control study, and there was one group of patients that received EPO, and they drove their hemoglobin up to 13 to 13.5, and they left one group untreated, no EPO, the low hemoglobin group. And you can see there's a clear difference here. And the study showed that the high hemoglobin group had a higher risk of cardiovascular events than did the patients with the high hemoglobin. This led to the FDA's black box warning about EPO in CKD patients that you should not go above 11. However, let me go back to this study. This group did bad on the outcomes compared to this group, but nowhere did they look below 11.5. Nobody's done a study. Nobody can tell me what happens if you're down here. What happens to the mortality of those people? So we know that going above 11 may be bad, but below 11, we don't have any information at all except that retrospective data that we have. If you look at the other study that was done, the CREATE study was published at the same time. This was data from Europe again. The untreated group has a hemoglobin of 11 and the treated group up to 13.5. This study found no difference in complications and cardiovascular risk, but they showed no benefit. There was no benefit to driving the hemoglobin up. But I'll go back to the same issue is, yeah, these two are not different, no benefit. But is there benefit if the hemoglobin is 9 or 10 or 8? Nobody's done that study. We don't have the answer to that question, just the retrospective data that I've alluded to before. More importantly, the FDA in their deliberations looked only at risk of cardiovascular events and death. They did not talk about anything about quality of life and what hemoglobin and quality of life means to patients. And this is one single study. There are many studies on quality of life that the FDA ignored, would not allow into their discussions. And this study clearly shows that a hemoglobin of 11, quality of life issues become much more common. Physical symptoms, fatigue, depression, relationship to others, many other social, emotional things that are important in patients' lives that get totally ignored in the treatment parameter. So I'm somewhat concerned about the FDA. I think they said, yeah, being too high is low, but they've left us totally without information what to do on the bottom side of low hematocrits and hemoglobins. And this is a history of what's gone on here. This again is US RDS data, starts in 1996. Erythropoietin became available in 1990. And the use, the dark green curve here, shows the percent of patients receiving ESAs. And it's been steadily climbing from when it was first introduced to about the mid-2000s, when we found about 30% of patients that came to start dialysis were on EPO. With the FDA warning, the black box warning, the number of patients receiving EPO has dropped off. And maybe that's appropriate. I can't tell you that. I'm not sure. We'll find out over the ensuing years what a low hemoglobin of 8, 9 and the quality of life means to patients as this happens. With hemoglobin, with EPO, as you might expect, the hemoglobin in those patients receiving EPO caused them to present at dialysis with a hemoglobin about 10.5. And even without ESAs, the hemoglobin went up. And that was because physicians were beginning to treat these patients with iron. Most of them are iron deficient. So that reflects the use of iron. But it's beginning to drop off so that in 2012, about 10% of the patients now are receiving EPO when they arrive for dialysis. And the hematocrit is about somewhere around 27, 26, hemoglobin about 9 as they present for dialysis. And it's headed south. They're going to go further down. Transfusion rates are coming back. In olden times, we used to transfuse these patients, tons of blood transfusions. We've stopped at this period of time, and now transfusions are beginning to reappear. So we'll find out if the FDA was wise or not in their recommendations of what we do with ESA. I don't think the answer to this story is finally told. But we're left with this management approach. You should identify patients with a hematocrit less than 30, a hemoglobin less than 10. That seems to be the cutoff point, and measure their iron studies. If they're iron deficient, you should treat them with oral iron, 200 to 300 milligrams. And this is a dilemma because these patients often have gastric problems. They don't tolerate iron. To get them to take 2 or 3 iron pills a day is very difficult. But if you can get them to take iron and their iron studies go up and the hemoglobin does not go up, you should consider starting erythropoietin subcutaneously 80 to 100 units per kilo and continue to monitor the hemoglobin and hematocrit. You do not want to go above 30, following the black box warning, or a hemoglobin of 10. And you should not start EPO probably if you're above that level. And you should not increase the hematocrit faster than 2%. Now, if you have patients in whom you've given iron and EPO and they continue to be profoundly anemic, I suggest you look for other etiologies of their anemia, because many of the diseases that cause low hematocrits, myeloma, different hematologic diseases can show up in these patients as well. So now I turn to the third leg of the stool of complications of CKD patients. And that is osteodystrophy or metabolic bone disease and its associated vascular disease, which has been and has become a more major problem. This is a very simplified cartoon. I do not have in all the pathophysiology of bone disease and vascular disease in the dialysis patient, but very simply with renal failure, they don't excrete phosphorus, and so the phosphorus level increases. They don't convert 25-hydroxy into 125, the active vitamin D product. And in fact, in dialysis CKD patients, the levels of 25-hydroxy are low. So they have low vitamin D, high phosphorus. That lowers the serum calcium in these patients, which then stimulates the parathyroid gland to increase PTH, PTH goes to bone, causes the reabsorption of bone, allowing calcium to go back up, and increases the gut absorption of calcium. This is a homeostatic mechanism that the body does. Unfortunately, PTH has its own deleterious effects with systemic toxicity and vascular findings. So does increased phosphorus. And low vitamin D in and of itself has myocardial cell and vascular cell pathophysiology. So this is a real problem in the dialysis population and something that needs our most keen attention. You should start by measuring the serum creatinine and phosphorus anywhere from 1 to 4 months, depending on the level of renal function. Early in renal disease, probably every 4 months is fine. As renal disease progresses, you want to check those two parameters more closely. Trying to maintain a phosphorus of 4.5 to 6 and a serum calcium of 8.5 to 10. You can do this by restricting phosphorus, and again, I've talked about that dilemma. Or you can use phosphate binders, calcium acetate or calcium carbonate if the calcium is low, the serum calcium is low. And if the calcium is high, you could use 7-lemur carbonate after meals. Again, getting dialysis patients to take these binders, which makes them constipated, makes them feel full, is a full-time job for a dietitian. Now, I've suggested, and this shows among many other studies, that with progressing renal insufficiency, there's a drop in the 1,25-dihydroxy, but also there's a drop in 25-hydroxy, ergocalciferol or cholecalciferol. Now, we found this out in dialysis patients about 15 years ago, and I think in the subsequent 15 years, in many other fields of medicine, low vitamin D levels are being reported. They're being reported in cancer patients, they're being reported in prostate cancer patients. Any chronic disease category, people are now beginning to find low vitamin D levels. And what do you do with that? What's the meaning of that? What do we do about that? Is not entirely clear to me, but I think that most nephrologists that I talk to at this point are measuring the vitamin D level, the D-hydroxy level, at least annually. Some are measuring it more often than that. And if it's low, starting 50,000 units of ergocalciferol a week or 1,000 to 2,000 units of cholecalciferol daily to attain a normal 25-hydroxy level. There are no studies. I've found nothing that suggests that the patients benefit, but a low vitamin D level seems to be associated with a lot of other disease processes. And so I think most nephrologists are doing this now, giving oral vitamin D early in CKD. The role of 125, the active vitamin D in this population, is much less clear. In fact, there's a recent study that shows that there is no benefit in cardiovascular or vascular disease when given 125, the active product, in CKD patients. Has a different role in the dialysis patient, but in CKD patients, that's very questionable. Not much data to support that, but most of us are given vitamin D. And finally, you must monitor the parathyroid hormone. I think semi-annually for most CKD patients. As disease progresses, you may want to order that more frequently. If the serum PTH is 150 to 300 picograms or greater, you should consider an oral vitamin D product, either Rocaltrol or Hectorol. And if the value of PTH goes higher, 500 to 800 picograms, that's about 40 times the normal value. And it's very rare, but if it occurs, you should consider calcium mimetic agents, ones such as senecalcet or Sensipar. So that's kind of the approach to a very important aspect of chronic kidney disease. The next bundle of therapy is related to cardiac disease and vascular disease, and I'm going to go back to the slides that I just showed you again. This is the comorbidity at initiation of dialysis of cardiovascular problems. Dialysis patients show up with frequent cardiac arrests, cardiac dysfunction, myocardial infarctions, coronary artery disease, congestive heart failure, and a very high percentage of LVH related to their hypertension and fluid overload. So cardiovascular disease in the CKD terminal population is very common. This is from the USRDS, which shows point prevalence of stroke, congestive heart failure, and acute myocardial infarct in a large population of patients without CKD. If you look at a population of patients with chronic kidney disease, stroke goes from 20 to 26%, congestive heart failure from 20 to 44, almost doubles, and acute myocardial infarction increases from 6% to 12, almost 13%. So kidney disease is a frequent harbinger of cardiovascular disease, and the two together don't go very well. Risk of cardiovascular disease is 1.4 to 2 times with a serum creatinine greater than 1.5. Risk of coronary vascular disease is 1.5 to 3.5 times if albumin appears in the urine. The annual mortality from cardiovascular disease is increased 10 times with kidney failure, and probably 20 times in the diabetic with kidney failure. So diabetes, cardiovascular disease, and CKD are a bad combination. So how do you approach this terrible problem of cardiovascular disease in this population of patients? Somewhat differently than you would your other patients, because of this important part of calcium phosphorus PTH abnormalities. This clearly leads to atherosclerosis with intimal and medial calcification. The myocardium is affected, vessel occlusion, and valves are affected by the calcification, in addition to the significant role of long-term hypertension in this population of patients. In addition to that, there are other uremic-specific effects on the cardiovascular disease: volume overload, oxidant inflammatory stress, dyslipidemia, homocystinuria, uremic toxins, and a particular effect on smooth muscle cells in the renal failure patient. These maybe you can control somewhat with dialysis, but dialysis itself has risk. We change the electrolyte package in patients all over the place when we dialyze them, and we stress them with volume. We do cardiac stunning because we take volume off of them during dialysis, and so it has its own risk, in addition to the classical cardiovascular risks that you all deal with. So the CKD patient is different because you have to deal with all of this other stuff in these patients. And I think probably this is of prime importance in reducing the risk of cardiovascular disease in the population, along with control of hypertension. So the final bullet, getting the patient ready for dialysis. You play an important role in that. I suggest the nephrologist at this point is going to become the primary player, but I think internists and primary care docs really play a crucial role. This is a cartoon that shows the cost of kidney care. This is payment per patient per month in thousands of dollars, and you can see in the slow early part the costs are low, but as the patient approaches the need for dialysis and complications occur and hospitalizations increase, medications increase, the cost goes up, and then they start dialysis, they start getting better, and this curve tapers off. So what we'd like to do is get rid of this peak of cost here, and we can do that by earlier preparation with a smoother transition into dialysis and transplantation. It really will have profound impact on the cost of care of these patients, and it's all based on physicians, is my belief. This is a USRDS study, again, showing the cumulative probability of a physician visit at 12 months following the diagnosis of kidney disease. This is Medicare patients and market scan patients, and you can see that of patients with CKD, about 90% of them within a year of the diagnosis are going to be seeing a primary care physician, which is excellent. About 60% of them will have seen a cardiologist, but only a third within a year of having the diagnosis will have seen a nephrologist. Maybe that's good, maybe that's bad. To me, in the nephrology group, it's probably bad. We think we ought to be playing maybe a little bit more of a role there. But even in the commercial patients, it's the same pattern. Now, it may be important, and it depends on when you see the patient. This is a study from Junger from a few years back looking at when patients saw a nephrologist. This box is patients that saw a nephrologist greater than 6 months before their first dialysis. And this box shows if they were seen by a nephrologist within 15 days of the start of dialysis. And this is the length of the first hospital stay. So if you've seen a nephrologist before, that first hospitalization is reduced significantly from 30 days to 5 days. And more importantly, looking at mortality, those patients that saw a nephrologist for greater than 6 months before their first dialysis had this is a 3-month mortality of 1.6. The mortality, if they saw the nephrologist within 15 days, is 7%. That's a 4.5-fold increase in mortality. So certainly, in the last 6 months of CKD, having a nephrologist involved, I think, is extremely important. So when do you do that? When do you refer to us? Stage 3 or stage 4 is probably about right, but it depends on the rate of progression. Patients progressing really slow and things are okay, maybe you don't send them until the GFR is 30. But if they seem to be having a lot of trouble and not doing well and progression is coming up rather rapidly, the nephrologist probably ought to see the patient earlier because bad things are going to happen to that particular patient. It's usually predicted by poorly controlled hypertension, poorly controlled diabetes, those diabetics that you never get under any sort of control, or they have heavy proteinuria, or heavy proteinuria for any cause for that matter. And any possible uremic symptom, if you're following a patient with CKD and they've developed symptoms that you think may or may not be uremic, refer them to a nephrologist to clarify that. So that's kind of a rough scale of where I think around the country most nephrologists are expecting to see patients. So when they see the nephrologist, what do we do? What are the options for us? There are 3. Hemodialysis, either in a center or at home. Peritoneal dialysis, either ambulatory during the day or at night with a cycler, or transplantation from a living-related donor, a living unrelated donor, or cadaver donor. Those are the choices that we have, or no treatment, and I'll talk about that in a minute. So transplantation is clearly the treatment of choice. There's no question that successful renal transplant allows the best long-term survival and the best quality of life. There's just no question that your first issue with every CKD patient is to try to get them towards a transplant. Graft survival is higher for living-related and living unrelated than cadaver. In addition, the cadaver patient has to compete with now probably about 50 to 55,000 patients that are on waiting list in this country. And although this slide says in some units, some transplant programs transplant early, for the vast majority of patients, they're waiting 2 to 4 to 5 years to get a transplant. So there are clearly advantages in a living and an unrelated donor. And in particular, the concept of a preemptive transplant. That is, you're following the patient along, they got a creatinine of 4 or 5, a clearance of 60 cc's per minute, relatively asymptomatic. You should start your conversation with that patient about, do you have a family member that would give you a kidney? Do you have a friend? Is there some way that we could do a living or an unrelated living transplant and get the patient worked up well before they need the dialysis, because you can totally skip dialysis, go straight to transplant. Those patients do exceptionally well. You reduce a lot of costs and you reduce a lot of morbidity that they go through while going through dialysis. So this is a concept, and I know that it's done here. It's an important concept and one that around the country is highly supported. Peritoneal dialysis, I'm not going to go through these. I just want to point out that this is a therapy that's done at home, and it's the only therapy that's done at home without a helper. If you're going to talk a patient into doing dialysis at home and being independent, and you tell them, oh, by the way, your husband has to come 3 nights a week and has to spend 6 weeks learning how to do this, that really is a barrier to doing home therapy. But if you do PD, you can do it alone. You don't need a helper. And it is an excellent therapy. It gives the patient great independence. If you're going to do PD, the other advantage is the catheter only has to be placed 2 to 6 weeks before its use. Heals well, can be used quickly, only, in my experience, when it's put in by an experienced nephrologist and surgeon. You want somebody that knows how to put these catheters in so they can be used early. Hemodialysis, I'm not going to talk about at all except for one aspect, and that is the vascular access. And this is where I think primary care and internists play an exceptionally important role. This is data from Fresenius, the company I represent, looking at dialysis patients with fistulas, grafts, and catheters. Using patients with fistulas as a reference, we looked at the risk of death with a catheter, and it was about 1.8 times that of a patient with a fistula. And that's largely because of the risk of hospitalization from bacteremia or sepsis. These things get infected all the time. They're opened and used 3 times a day. You've got numerous people touching them. It's very difficult in the outpatient setting to get a real septic screen set up. So septicemia with a catheter is a problem. 3.5 to 4-fold increase in the risk of a hospitalization for septicemia. Moreover, and again in FMC data, we found cuffed catheter bacteremia 2.3 episodes per 1,000 patient days, very common. Half of them are Staph aureus, serious septicemia. Major complication in 1/4 of the patients. 1/4 of our patients died or had a major complication, and less than half had a serious metastatic complication. These are bad things. I have friends that call the AV catheter the white hose of death. And he uses that when he talks to his patients about why they should not have one. Well, the focus has to be on early placement. Somebody must talk to the family and the patient early on about what the options are. If you can do a preemptive transplant, you avoid this. If you can do peritoneal dialysis, you avoid this. And if hemodialysis is likely, you should take steps to protect the venous system in the patient. Routinely make sure that you've labeled one arm as, I'm going to use this arm for a fistula someday. Don't stick it. Avoid PICC lines when you can in potential dialysis patients. They're deadly to our patients. And most of all, don't use subclavian vein catheters. If you thrombose the subclavian vein, that extremity is gone forever for any sort of vascular access. So this is a particularly bad thing to do to a CKD patient. Although some surgeons say, I can have my fistulas up and working in a couple of months, I don't find that to be the case. Across the country, in general, it takes about 6 to 12 months for a fistula to mature, and it takes about 3 to 4 months for a graft to mature. So you really have to start thinking about this early in the process. Most of these patients are asymptomatic. They're tooling along, they're doing pretty good, and you have to have a conversation with them about putting in a fistula. They're going to think you're crazies. I don't want to go have surgery done on my arm. I feel okay, doc. I don't want any of this therapy. And if you listen to that and do that, they will cascade into uremia, and there you are putting a catheter in. So if a catheter is necessary, if you get to that point and you put it in, it should be a tunneled IJ catheter, I think, in this country, in this day and age. And you should make immediately plans, although you have the catheter, make immediately plans for an AV fistula or an AV graft. Referral is important. This is a study from Maine by Candace Walworth in which she showed with an early referral to a nephrologist, and that's before 6 months, 46% of those patients got a fistula and only 35 got a catheter. Urgent referral was when she saw the patient within 2 months. Fistula rate drops to 21%, catheter rate goes up to 62%. And when she saw the patient in the emergency room needing dialysis that day or that week, fistula rate drops to 2%, catheter rate's up to 85%. In this country, across the board, patients are presenting to dialysis using a catheter in 75% of the time. So we're still not doing a very good job with avoiding catheters in the United States. I'll talk briefly about survival of patients, and only one slide here that shows you as the GFR drops. And I've suggested in the elderly this is a problem, and in diabetes and with hypertension that's a problem. And overall, even in early CKD, there's a significant increase in the risk of death. Again, I think more active and aggressive treatment of these patients will affect reducing that mortality. And the cost of all of this is shown here. This is a slide that shows the incident ESRD population, the prevalent dialysis population, and the prevalent ESRD population. This is 2002. You can increase these numbers by about 15% at this point. So there are somewhere around 500,000, 550,000 patients that are receiving some sort of ESRD therapy in this country. This is a USRD population study looking at population and cost. You can see that in this population, diabetes occurred in 22% point prevalence. Congestive heart failure is 9.6 and CKD is 7. Here are the cost comparisons. Diabetes is more costly. Congestive heart failure is more costly. But look at CKD, the cost compared to the population. 0.6% of the Medicare population is CKD and ESRD patients, and we consume 4% of the Medicare budget. So this is a very costly disease. This is a slide that came from the USRDS, and this slide I first saw in 2000, and at that point they said, well, based on 1998 data, we think that by the year 2010, we'll be spending $28 billion on ESRD and CKD. The number last year was $31 billion. So this is a really costly therapy. One other thing I'd like to just briefly mention is survival. Does dialysis work? Yeah, it keeps people alive. It's kind of like a parachute. All comers, comparing dialysis and non-dialysis with survival, dialysis keeps people alive. But if you select out those patients with really high morbidity, metastatic cancer, stage 4 New York heart disease, Alzheimer's disease, neurologic disease, stroke, and you look at their survival on and off dialysis, there's no difference. So age doesn't make any difference. Gender shouldn't matter. Race shouldn't matter. But you should be very careful in the selection of comorbidities. Why would you put a 65-year-old severe Alzheimer patient with prostate cancer on dialysis? We see that all the time. I don't understand that. Very costly, not going to have any quality of life, and it really runs the cost up. So we as a medical community do a better job with selecting the patients. I think we can drive the cost down in addition to the things I've talked about. So other considerations are related to the outcomes, the quality outcomes I've talked about of delaying renal failure progression, minimizing complications, reduce cardiovascular mortality. That is the booger bear in our population. Refer patients early and timely for consideration of transplant and dialysis, and consider carefully the appropriateness of candidates for dialysis and transplantation. If we do that, I think we'll do a better job. I think most of the nephrologists look forward to close working communication and collaboration with our internist and primary care physician colleagues. Thank you very much.
Questions for Dr. Weiser?
Here?
Is there any other indication for using combined therapy with ACEs and ARBs besides the uncontrolled proteinuria?
Well, hypertension. I'm not aware other than albuminuria. The studies without, the slides that I showed you with the studies in which an ACE was used showed no difference. There have been 3 studies that I'm aware of with ARBs that were identical, and combination studies I'm not aware of. Perhaps any of you aware of a combination ACE-ARB study? I'm not aware of any outcomes that I've seen with the combination, but would be an interesting study to look at.
Dr. Weiser, there's, I think, 3 recent studies that have suggested that we're starting patients on dialysis early. And what's your comments on that? Is that an epiphenomenon of the argument equation? Is that we've never been able to look at the first 90 days? Is it real?
Well, I think it's a selection problem in the study. I know the study you're talking about, and what happens is that sicker people, because they're sicker and they have more problems, get started earlier. I mean, that's what doctors do. When things start falling apart, you put them on dialysis. And so I think that clearly was a reflection, because they didn't control for that. They did not go back and figure out, well, sicker patients started and sicker patients require dialysis for this reason. So I think it's an epiphenomenon. I was at the forefront, along with Ray Hakeem, a number of years ago when we looked at malnutrition and said we're waiting way too late. We let these people get way too far down and they get too sick and we never can get them back. And so we were advocates of starting early. At that point, starting early was a creatinine clearance of 5 cc's per minute. It's now gone to about 15 cc's per minute. Maybe that's too early. And I think you have to base that not only on the clearance the patient has, but their symptoms. When they start becoming symptomatic, I think you have to intervene.
I want to again thank you
Very much.